Good afternoon, everyone. Thank you so much, Dr. GVK sir, for this honor, and honorable chairpersons as well. So I think you were really testing me when you gave this topic to me, because to complete skin in 10 minutes is really a very tall order. So anyway, I think we all know what skin is, the structure of it, what the integumentary system is. But what we fail to acknowledge is that it's really a reflection of inner health or inner disease, and it can really give us a lot of hints as to what's going on within. So your skin is the fingerprint of what is going on inside your body and all skin conditions. Very rightly said so. At least 1/3 of our patients or people living with diabetes have skin manifestations of different kinds at different stages in the disease process. More often, infections are seen with type 2 diabetes, and then autoimmune conditions with type 1 diabetes, as you can imagine. In fact, these skin manifestations or conditions that develop may be the first indicator of disease, and besides aesthetic concerns, actually we need to be concerned about the inner complication that it's indicating. And it may be secondary to metabolic effects on microcirculation as well as the skin collagen. These are the key defects that we see in most of the skin conditions associated with diabetes. So the key is to recognize them and then prevent them, of course manage them well. So I've just enlisted some of the most common or well typified conditions seen in type 2 diabetes as well as in type 1. And I'm just going to walk you through some of them, highlighting some of the important features associated with them. So periungual telangiectasis, as the name suggests, we've seen it in up to 49% of those with diabetes. It arises in the nail bed after the loss of capillary loops and the dilatation of the remaining capillaries. How it presents is that there is a lot of tenderness around the nail bed, and the erythema is very visible, also ragged cuticles. And no treatment is really necessary for this because it improves with good glycemic control. The next is necrobiosis lipoidica. This is rare, but again more common in women as compared to men, and again seen in more with type 1 diabetes as compared to type 2, and it usually is a marker for diabetes. So if you see this condition, you should evaluate the patient for sugars, and usually it's multiple, bilateral, pretibial, and has these non-scaling plaques, which I've shown you in the picture, with an atrophic center, surface telangiectasis, and then a violaceous raised border. Pathophysiology, like most skin conditions, not really known, but then again precipitated by localized trauma, microangiopathy, immunoglobulins, and then metabolic changes as well. It does not correlate very well with how well the diabetes is controlled somehow. But it also is prone to ulceration, and hence trauma needs to be prevented. We also have this bullosis diabeticorum, which is slightly more common than the previous two I described. These are distinct, spontaneous, non-inflammatory blisters on the acral skin looking like burn blisters. And they are more seen in men as compared to women, especially when there is long-standing diabetes and also peripheral neuropathy in tandem. Again, cause is multifactorial, and three main types have been seen. One is a very common type that I've shown you here, another is a hemorrhagic type, and then there is a non-scarring type as well. These are self-resolving. If you feel that the patient is really inconvenienced, they can be aspirated without breaking them. Vitiligo, again this is a very common condition, but more so in type 1 diabetes as compared to the general population. Again, combination of biochemical, cytotoxic, neural, autoimmune, and genetic factors for vitiligo, and all you see is hypoachromic macules surrounded by healthy skin, ranging from a few millimeters to even large patches. And this is due to the loss of cutaneous melanocytes. May be treated very well with topical steroids as well as UVB light. Lichen planus, we often struggle with the diagnosis of this condition. These are inflammatory keratotic dermatitis causing condition with an unknown origin. What you see is polygonal erythematous flat lesions. And when it occurs in the mouth or the oral cavity, you will see a white lacy pattern, which probably if you once see, you will never forget. Again, may respond very well to topical or intralesional steroids, systemic steroids, or even phototherapy. One of the commonest conditions that we see is yellow skin and nails. Almost 50%, 40 to 50% of all our patients have this if we really take the time to observe. Even more so in our elderly patients and most evident at the distal end of the hallux, caused by hypercarotenemia and protein glycosylation end products. Diabetic thick skin is equally common in both type 2 as well as type 1 diabetes and heralds as a marker for diabetic retinopathy as well. Who would have imagined that? Well, it's because of increased stimulation of insulin with the background of insulin resistance and then non-enzymatic glycosylation of collagen, which causes the collagen to form these cross linkages and is not amenable to the degradation process. So there is increased amount of collagen collecting in the skin at localized forms, localized regions. And then there are three main forms identified. Besides the general asymptomatic ones, the most severe form is the diabetic scleroderma, which again, few of us might have seen them. Acrocordons, these are nothing but the skin tags. And again, family history, obesity, inflammation, and hyperinsulinemia are the hallmarks of these. This is because of hyperinsulinemia due to insulin resistance that ends up activating the IGF receptor, leading to keratinocyte and dermal fibroblast proliferation, and that's how you get these. But mind you, if there are more than 3 skin tags seen collecting at a spot or at multiple sites, do look out for the sugars of this patient because this is a forerunner for diabetes. These are mostly benign, however, they may change into a malignant form, and again there may be abrasion or necrosis seen as well. These are commonly seen in the axillae, eyelids, neck, groin, and again, I think mostly for cosmetic purpose, the patients may seek help for the same. They can be either removed with forceps or even more sophisticated procedures like using the photocoagulation, cryosurgery, or even the lasers. Diabetic dermopathy. This is one of the most commonly seen skin manifestations associated with diabetes. They are pigmented pretibial patches or skin spots. Approximately 50% of our patients live with this. What you see are multiple asymptomatic, round, brown, dull red to pinkish papules or plaques ranging from 1 centimeter to even 2.5. They may be benign and the underlying mechanism is not really known but definitely associated with other microvascular complications, and it is due to the hemosiderin deposits. More than 4 lesions or at least 4 lesions at a time indicate diabetes. So again, we need to screen these patients if the skin condition has come up even before they know they have diabetes. It is associated with the duration of diabetes and poor glycemic control. These seem to heal and disappear, leaving atrophic hypopigmented patches at the site. Acanthosis nigricans, I think this we all are absolutely familiar with. It heralds indicates insulin resistance, and again it's because of the excess circulating insulin that binds to the insulin-like growth factor receptors and stimulates the keratinocytes and dermal fibroblasts, pretty similar to the pathogenesis underlying the skin tag formation. These are hyperpigmented velvety thickening of the skin folds, and seen especially in the intertriginous areas. Although largely asymptomatic, these can become painful, they can actually become macerated or even ulcerated, and they can emit a foul smell as well. The dark color is attributed to thickened keratin containing superficial epithelium. These are reversible in nature provided there is intense weight loss, improvement in the lifestyle, and also reduction in insulin resistance. Acquired perforating dermatosis, this is again a condition not very commonly seen, marked by small umbilicated dome-shaped papules and nodules with a hyperkeratotic plug on extensor surfaces which are very, very itchy, and also there may be Keebnerization. The patient may say that the minute I hurt my elbow or I hurt my the skin surface to another object, I start getting these lesions all over. The pathogenesis is unknown, but defective differentiation of the epidermis and dermal epidermal junction due to alteration of glycosylation and diabetes are known factors. It is associated with diabetes and even chronic renal failure. Some of the other common conditions that we see with diabetes are as follows, and I'm not going into the details because these are not as commonly seen, but the commonest are cutaneous infections. I'll finish in a minute. We all know why, because of associated with poor glycemic control and because of poor microcirculation, peripheral vascular disease or neuropathy, and even the decreased immune response. Candidal infections are commonest, and again we know where they thrive and how they feature, but a special mention should be made to Candida paronychia, intertrigo, and onychomycosis. These are fairly difficult to treat and they take much longer to actually heal. Dermatophyte infections are very common in the Indian setting with all the sweating, uncontrolled sugars, and poor hygiene. Again, these are very common in the skin OPD. Bacterial infections may not be as common, but worthwhile knowing because they need to be differentiated because the treatment will depend on the same. So in summary, diabetes is a systemic disease with manifestations affecting every organ system. We know that. Skin lesions or manifestations may be a marker for underlying metabolic complications, pre-diabetes, or a forerunner to diabetes itself. It's important to ask leading questions about skin diseases and infections and either test, treat, or even refer to the correct physician for the same. Investigations for a thorough evaluation of skin conditions as systemic implications are far-reaching. And early detection and consistent glycemic control are key to preventing complications with skin disease. These are the references I used.